Hello everyone, welcome to Raaonline. This is Dr. Aditi. I'm a consultant in internal medicine and today we are going to learn how to approach a patient with disturbances in the phosphate metabolism. So in today's session, we'll be looking at what is normal, what are the different factors that will affect phosphorus balance. We'll be looking at the causes of and the management of hypophosphatemia and hyperphosphatemia. So let us move on. What is normal serum phosphorus? Normal serum phosphorus level refers to a serum phosphorus level of 2.5 to 4.5 milligram per deciliter. Now, phosphate, as we all know, is an integrate component of cellular structure in the form of DNA and RNA. It is also required for energy storage, for ATP production, and also plays a very important role in oxygen transport through 2,3-DPG. Now, phosphorus is secreted. Phosphorus has an intact, very specific circadian rhythm with the highest levels of the endogenous phosphate being observed at 3 am and lowest levels of endogenous phosphate being observed at 11 am. So, phosphate is seen to follow a specific circadian rhythm. Now, normally, on an average, an individual consumes somewhere around 1 to 2 grams per day of phosphate in his diet, of which about 0.6 to 1.2 grams is absorbed from the intestines, specifically at the jejunum. In addition to intestinal absorption, about 90% of the serum phosphate is actually reabsorbed at the kidneys. 75% of absorption happens at the proximal tubule through sodium phosphate cotransporters. 15% of the reabsorption happens at the distal tubule and about 10% is lost in the urine. So, let us look briefly at the various sodium phosphorus cotransporters. Now, these transporters, they function against the concentration gradient by transferring the phosphate into the cell. Now, type 1 transporter is present predominantly in the kidney and also found in the brain and liver. Type 2 transporter, there are 3 subtypes, 2A, 2B and 2C. Of these, it is important to remember that 2B is absent in the kidney. B is absent in the kidney. It is present only in the gastrointestinal tract and the lungs and plays a very important role in the gastrointestinal absorption of the dietary phosphate. Now, 2A is predominantly found in the kidney. 2A and 2C are found in the kidney at the proximal renal tubule. Now, 2A plays a very important role in the renal phosphate homeostasis, whereas 2C takes care of growth-related functions. And finally, the type 3 transporter is present ubiquitously in all the cells and they regulate the intracellular phosphorus levels. Now, having looked at the sodium phosphorus cotransporters, there are 3 types. Almost all the 3 types are found in the kidney except for one subtype of the type 2 transporter, which is 2B. 2B takes part in the intestinal absorption of the dietary phosphate. All the other transporters are present in the kidney. Type 3 transporter is present in all the cells and regulates intracellular phosphate. Now, having understood that, let us look at the factors which affect the renal phosphorus reabsorption. Now, insulin, estrogen, thyroid hormone, growth hormone, volume depletion, chronic hypocalcemia, metabolic alkalosis, all of these factors increase the renal phosphorus reabsorption. That means all these factors, by increasing renal phosphorus reabsorption, what happens to the serum phosphorus level? The serum phosphorus level, because renal reabsorption is increased, serum phosphorus level is increased. Now, what happens on the other side? You have parathormone, phosphatonins, volume expansion, chronic hypercalcemia and metabolic acidosis, all of which decrease the renal phosphorus reabsorption. So, these factors decrease the renal phosphorus reabsorption. Therefore, what happens? So, having understood fully about the sodium phosphorus transporters, let us look at the different factors which affect the renal phosphorus reabsorption. Now, on one end, we have insulin, estrogen, thyroid hormone, growth hormone, volume depletion, chronic hypocalcemia and metabolic alkalosis, all of which will increase the renal reabsorption. So, when these factors increase the renal reabsorption, what happens to the serum phosphorus? The serum phosphorus levels increase because the reabsorption from kidneys is increased. Now, on the other hand, we have parathormone, phosphatonins like FGF23, fissile-related protein 4, volume expansion, chronic hypercalcemia and metabolic alkalosis, all of which decrease the renal reabsorption. That means what happens is, in all of these situations, there is an increased renal loss of or renal wasting of phosphate that results in decreased serum phosphorus levels. So let's dive straight ahead into hypophosphatemia. Now let's start with trying to understand the different causes of hypophosphatemia. Now when I say a patient has hypophosphatemia, it could mean that there has been decreased intake of phosphorus or increased excretion of phosphorus or a transcellular shift, causing an increased shift of the phosphorus into the cells.